Hi, good evening, everybody, and welcome to the Rare Diseases South Africa webinar sponsored by Novartis. And tonight we are tackling rare blood cancers, and we have got a quality panel of speakers ahead of us tonight. So, tuck in, put on your seatbelts and get ready, because we've got a jam-packed hour ahead of us. We've got 4 quality speakers to pack into an hour together with discussion. So let's get on with it. I'm Helen Malherber from Rare Diseases South Africa, and I head up the research. So greetings from Rare Diseases, and thanks once again to Novartis. What we're going to do tonight is we're going to have 4 very short introductions by our 4 speakers in terms of who they are, where they're from, and how they fit in. And also just to give an overview of a specific component of this condition as a part of the rare disease community. And then we'd really like to encourage our participants to write on the chat where you're joining us from, which part of South Africa or elsewhere in the world, and why you're joining us tonight. We'd love to hear from you. If you can drop that in the chat. And then if you have questions as we go along, drop them into the Q&A. And we can either answer them live in the discussion section, or we can do that as we go along by responding live. So with no further ado, I'd like to introduce Dr. Philippa Ashmore. She grew up in Johannesburg, and she's done some of her training in the UK at St. George's Hospital Medical School. And she then did her internship in London East End at Whipps Cross Hospital and the Royal London Hospital. And also at the Kingston Hospital, and then she came back to South Africa to complete her training, and it's here that where she specialized after discovering her passion for clinical hematology, and this was under the guidance of Professor Musa Patel. And I'm going to let her introduce the rest of herself so that she can give a better context of where she is, where she's coming from, and why she's here tonight. And she's going to tell us more about the symptoms, the diagnosis, and the care of some specific rare cancers. Thank you very much, Dr. Ashmore.
Thank you very much for the introduction, and obviously the opportunity for this kind of forum, which I think is incredibly important. As clinicians, we often talk to medical students or doctors or that sort of thing, but I think the opportunity to talk to patients is absolutely invaluable, and something that I certainly welcome. Again, thank you for the Rare Diseases for inviting me to talk today. It's a very short time period to discuss anything in depth, but just I've been asked to give a flavor of sort of ITP, so immune thrombocytopenia, and some of the myeloproliferative disorders. And then obviously you'll hear from a couple of patients with those disorders who can discuss some of the challenges they face. So let me just share my screen. Okay. So as the introduction said, I'm a clinical hematologist working in Johannesburg. And clinical hematologists are specialists in blood and bone marrow disorders. So I just want to do a quick overview of the bone marrow. So essentially it's where all blood and immune system cells are made. So it's really just taking a step back to contextualize these diseases. And it's not located in all bones, and as we grow older, it sort of recedes into the center of the body to really be the spine, long bones, and pelvis. And one of the most amazing things to my mind is really that all of this comes from a single stem cell. Obviously, there are millions of them, but that then multiply out and make all the blood, all the immune cells, and really do this incredible job by a very organized system. But obviously there are lots of points of vulnerability of the system. So just to cover ITP, so it used to be called idiopathic thrombocytopenic purpura, which is a hell of a mouthful. Now shortened to immune thrombocytopenia, which really describes it better, even though it's all Latin. Where it's an autoimmune disease where the immune system kills platelets. So you end up with a low platelet count. In an individual patient, because it's quite a wide ranging disease in terms of how it kind of manifests in a single person. But there's lots of different triggers that ITP patients will describe, and they're different from one patient to the other. The exact immune cells responsible are different, so the treatments may be different from one patient to another. And the site where that destruction happens may be different. So the bone marrow, the peripheral blood, the spleen, other places. And like I said, ultimately it leads to an increased risk of bleeding. So whether that's spontaneous or it's just disproportionate. So if you knock yourself on something and your whole leg bruises, for example, I mean, that's not normal. The kind of signs that patients would report, really, it's new onset is important. So it's not something that somebody's always had. And it tends to affect young patients particularly. And that picture really depicts a phenomenon of bleeding into the skin. So doctors, you know, we love using these complicated terms. Mucocutaneous bleeding is it, which basically means the skin and mucous membrane. So nose, gums, women may have heavy periods, things like that. Those are the sort of typical sites where an ITP patient may bleed. I think something that's really important that's not really taught in medical school, but you learn to appreciate it when you come across patients, is fatigue is a major symptom here, and it's very badly dealt with. Another thing unrelated to the fatigue, so the fatigue seems to happen when patients are having flares, but they develop an iron deficiency as a complication because they're often bleeding sort of slowly in the background. Life-threatening bleeds are quite uncommon, but they can occur, and I've certainly come across patients where this is the case. In terms of making the diagnosis, it really is about access to somebody who's seen it before. So the medical history and examination, you can almost make the diagnosis on that, but we do need some blood tests too. And really the importance of the history examination is to make sure that there's not a broader problem going on, because ITP can, or low platelets can be part of other blood disorders. So it's really making sure that you're not missing something essentially. You'll have a blood count, some baseline chemistry, some infection markers. You might have scans depending on what other symptoms you're having. Importantly, a bone marrow biopsy really doesn't form part of the diagnosis anymore, and it's only used if somebody isn't responding to therapy, so you think maybe you've got the wrong diagnosis, or you know, there's something in the history or examination that makes you think there's something else. In terms of treatment, because it's often turns into a chronic illness, so this sort of grumbling along illness with periods of relapse and remission, it really depends on what the clinical situation is, how you manage it. So the steroid or prednisone, whatever version of steroid you want to use, really should be in a pulse form. Really long gone are the days where patients would be stuck on prednisone forever and just have all of the horrible side effects that can come with that. You know, you use little pulses to bring them up, and then if they require something longer term, then there are alternates. In the emergency setting, there's a role for a drug called Polygam, which is where you basically give antibodies derived from other patients, where it's really a distraction technique for the immune system to kind of get it off in another direction and move it away from the platelets. Splenectomy is not done anymore. There are some circumstances where it might be considered if you really don't have access to anything else, but it really is the one thing you can do to a patient to put their life at risk. Other kinds of immune suppression in the longer term. So these are some of the medications that a person might be put on that target different kinds of immune cells. And in one patient it will work, in another not so much. And then the newer agents now, romiplostim or Nplate and eltrombopag or Revelade, are used to simulate platelet production. And that's really, you know, in first world countries, those are the drugs that are used almost upfront. We're getting to a place where we can do that now, depending although on your funding and your medical aid plan and things like that. And in the state sector, these drugs are not really available. So moving on to myeloproliferative diseases, I think it's often a difficult diagnosis or group of diseases to communicate to a patient because they are cancers. And there's a lot of doctors who shy away from using that name. And I think it's a mistake because they're going to hear it at some point, whether it's on the internet or somewhere else. And it's very important to contextualize it properly for a patient. So it is a group of bone marrow cancers. It tends to happen in older patients, although there are young patients with these disorders. And the reason it's a cancer is because there's a mutation that happens in the stem cell. So this myeloid stem cell, which makes all of these products. And an example of that is a JAK2 mutation, which a lot of patients will be aware of, but there are others. Now, basically all of the different myeloproliferative neoplasms, MPNs, result in an overactivity of a particular cell line. Now, whether that's leads to higher numbers in the blood or sometimes actually low numbers, depending on their survival. It depends on the disease and the situation. These are the diseases included in that group. So Polycythemia Vera, essential thrombocythemia. So Polycythemia Vera is supposedly predominantly along the red cell line, although you can get increases in other cell counts. ET is where your platelets go up, so thrombocythemia is a high platelet count. Primary myelofibrosis is probably the more aggressive of all of these. And this is, sorry, excuse me, the wind has blown my door open. Go. So the primary myelofibrosis, like I was saying, is probably the most aggressive, and it's actually these megakaryoplasts, so a precursor to the cells that make platelets, become the cancerous clone, and they lay down a lot of fibrous tissue or scar tissue within the bone marrow, and makes it very, very dysfunctional and poor producing blood, and you end up with an enlargement of your spleen as it tries to take over that role, and it's not very good. So you actually end up with a very big spleen and very low blood counts potentially. So that's a little bit different from the sort of overproduction idea, although, like I said, there's an overproduction of these cells in particular, which leads to lower blood counts. Then these two are very rare, so I'm not going to go into them at this point. I would suggest for time purposes, we'll focus on myelofibrosis and a little bit on these two. As with all medical conditions, there's always a not otherwise specified or a doesn't quite fit into the box category, which is what that one is. So in terms of signs and symptoms, it just really all relates to dysfunction in a particular cell line, sometimes all of them. And occasionally, such as in primary myelofibrosis, in a very aggressive form, it can result in a failure of the bone marrow. In terms of what patients feel, fatigue, 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 fatigue. And the problem with that is it's such a general thing that a lot of the times it's missed as being a cause. If patients have a low red cell count, they can be pale. If they've got a high one, they can be sort of ruddy in color. It's referred to as plethora. This hyperviscosity really talks about that overproduction of cells, and the blood becomes very thick. So it can cause headaches, shortness of breath, blurred vision, again, quite vague things. But when you sort of put the patient in front of you and put it all together, it makes sense. The burning feet and palms isn't well understood why it happens, but it happens in particularly ET, but can happen in the others. As the spleen enlarges in a lot of these disorders, you get early satiety, which just means you're trying to eat, and your spleen is so big that it squashes your stomach, and although you're hungry, it essentially your body tells you you've had enough. B symptoms, which often gets talked about: night sweats, loss of weight, loss of appetite, and what used to be included in that is itchy skin. And then ultimately how some patients present is that with all of these problems, thicker blood, which is not flowing very well, with lots of extra blood cells and very dysfunctional blood cells, you can get blood clots or in fact bleeding, because it's the same sort of two sides of the same coin, essentially. So in terms of the diagnosis, again, careful medical history and examination by somebody who's familiar with these disorders. Blood tests, just basic things, will give you a very good idea about what's going on, particularly a blood count. And not only that, you can see in some of these disorders, immature cells being pushed out from the bone marrow early. And if you know what you're looking at, then it will become clear there's, where the problem lies. Often there will be abdominal imaging just to quantify the spleen size and things like that. And sometimes just to make sure there are no clots within the abdomen, because that can happen in unusual places. And in this group of disorders, you have to have a bone marrow. The sample is very important to send for genetics, and those genetic tests are not genetics of the person, it's of the bone marrow and the cells that have become cancerous, because it really impacts upon prognosis and how you're going to treat the person. Because these days, honestly, we have access to technology and we can actually personalize treatment for a particular patient and a particular disease. So just to emphasize that, one size does not fit all. A patient has impact on their disease, and the disease has impact on the patient. And then the disease itself is, well, smorgasbord of different cells with different kind of targetable therapies, essentially. So you have to risk stratify the disease and personalize therapy to the person. So predominantly for ET and Polycythemia Vera, so where your platelets are very high or your red cells are very high, the idea is to reduce production or kind of the production load. So for example, with Polycythemia Vera, you might donate blood to get rid of the, the red cells, which make up the most of the blood. You have to address the risk of blood clots, so whether that's with aspirin or something stronger. And you have to monitor very carefully for acceleration of disease and progression. So all of these diseases can accelerate into more aggressive processes, which ultimately can end up with leukemia. It's rare in a lot of the diseases, but you really have to quantify what that risk is up front and decide how carefully to monitor somebody. In primary myelofibrosis, which, like I said, was probably the most aggressive of all of the myeloproliferatives, there's a targeted therapy launched in South Africa, so about more than 5 years ago now, I think. The trade name is Jakavi, and it targets the mutation in question and really does improve symptoms and improve quality of life for patients, and probably quantity of life too. So it's really an important development in these diseases. It is registered for treatment of these more aggressive forms of the ET and PV too. In high-risk patients, though, one obviously would still consider a bone marrow transplant, depending on the patient characteristics and the disease characteristics. You wouldn't even dream of it for somebody with very low-risk disease, because really they should live a lifetime without it. But if somebody has a very aggressive form of the disease and can tolerate a bone marrow transplant, has donors, etc., then you really would go that route. So in terms of, I suppose, actually hematology in general, but with these disorders, whereas before sometimes patients would have radiation, chemotherapy, all of that sort of stuff, we're really looking at outpatient care and moving towards targeted therapy. There is still a very specific role for stem cell transplantation, but not as key as it used to be, because the technology is advancing, like I said, and the treatments are much better. Personally, these are the ongoing issues for me, not necessarily in order of importance, but this is what I think the gaps are. Access to resources. So, there's lots of patients who have very delayed diagnoses because they don't go to a doctor who has experience in this area. access to the treatment and the diagnostics is not always there. The cost of the diagnostics and treatment is an issue, particularly in the state sector. And then I'm sure the people who come after me will talk in great detail about it's better now, but the lack of patient support. Because these are such rare diseases that a lot of people don't understand in the general public what it means to have them. And therefore, they don't quite know what to make of it when a patient tells their friend or colleague or boss that they have this illness and what it means. And it can be a very lonely place for patients, I think, which I'm sure the subsequent speakers will go to.
Great, thank you very much, Dr. Ashmore. That was very informative. What I always love about these webinars is you always learn so much. So thank you. We'd like to go to our second speaker now. We're going to take questions afterwards, but I've been dropping some in the chat as I've been going along, and Megan is checking the Facebook Live just to drop any questions in the Q&A as well. I just can't access the Q&A as a panelist in terms of writing a question. So we'll go to our second speaker now, but please feel free, panelists as well, to drop in your queries. We're going to get Danelle de Beer now. And Danelle is going to tell us her experience as someone that's living with ITP. She's been diagnosed for about 7 years this October, and it did change her trajectory at university, and she did have to change her, drop out of her course and her studies due to the side effects of the treatment. And she's going to tell us a little bit more about her journey and her story and how she faces the day-to-day in living with ITP and the various struggles, awareness spreading, and the importance of a support team. So I'm going to hand over to you, Danelle, and let's hear what you've got to say.
Hi, everyone. Sorry, I had a little bit trouble finding the video button, but my name is Danelle de Beer, as Helen mentioned. I am 27 years old. I was diagnosed in my second year of university. How I got diagnosed was a really long path to take. I had started getting nosebleeds and I was tired all the time. So during my end year exams, my nose wouldn't stop bleeding for 2 weeks. So I went home between my modules and went to my local GP, and he couldn't see anything wrong. And at the time, I didn't have any medical aid. So he took my full blood count, and when my blood count came back the next day, he said that he sees that my platelet count is 5, and a normal person's platelet count is between 150,000 and 450,000, if I'm correct. And so he urged me to go to the local hospital. And when I went, my platelets dropped from 5 to, I think it was 2 in a day. So they took blood again, and then they gave me blood transfusions, and it was a really traumatic experience because nobody knew what was going on. They did bone marrow testing, bone testing, everything they could imagine. They tested for like malaria, TB, and all those stuff. And I remember in the hospital the first time, the doctor said that he thought I had leukemia. Then they came back with the bone marrow tests results, and then he said, no, you don't have leukemia, you have lupus. And then they did more tests on me, and then he said, they don't know what I have anymore. So they sent me home with a prescription of prednisone, and I had to go back every 2 weeks to see if my platelet count comes up. And with the prednisone, it didn't help. So they prescribed more and more and more. And at the end of the day, they referred me to Baragwana in Johannesburg. And the hematologist over there diagnosed me with ITP. So when I went to Baragwana for the first time, they gave me a prescription of 32 5 milligrams prednisone tablets to take per day for about 3 to 6 months. And then they started seeing my platelets are going up slowly. So that's how I got diagnosed. And the day-to-day struggles, it's been 7 years now. And the thing that is really something that gets you is that the illness is inside of you. No one can see what's wrong. No one can feel how tired you are feeling or feel how sore your body is or any of those things. It's something that it's like depression. Everything is inside, but no one can see it. So you're fighting this invisible disease where no one can help you. You feel alone and you feel isolated. And the past couple of years have been better due to Novartis and Rare Disease South Africa that's bringing awareness to these diseases. Because before that, I didn't know anything about ITP. I had to Google everything I know. And you know, if you Google something, you're going to be diagnosed with death. And that's not the case in this. So it's nice to have someone to talk about, and it's nice to be able to spread awareness about something like this, to show the importance of being able to see that you're not alone. There's somebody else that has the same thing that you have. You have somebody to talk to. And if you're having a bad day, you'll be able to talk to somebody about that. And yeah, that's all I can say. So thank you very much for the time. And I really hope that anybody that has been diagnosed with ITP has the courage to reach out to the support systems and get the support you need.
Thank you so much, Danelle. Thank you just for your, speaking from the heart and just telling us your story. I think one of the things you said there, what a difference it makes just to connect with somebody else in the same situation. And it really comes down to that, and not feeling so isolated, and knowing that there are others out there going through the same thing as you, and it gives you that point of reference. And I know that's a huge help to so many of our members. So thank you, Danelle. We're going to keep going for now, and we'll come back to specific questions later. I'd like to now introduce Corno de Jager with my best Afrikaans accent. Corno is in his late 30s, and he was diagnosed much more recently in 2020. And I think what's interesting about Corno is it was through his work that he started to his symptoms really emerged. And while he could kind of pass it off for a while, it became clear that there was something else going on with him. So I'd like to hand over to Corno to introduce himself a bit more and to tell us his story, including his role in raising awareness and providing support in South Africa and further afield. Thanks, Corno.
Hello, as you heard, my name is Corno de Jager. So I was diagnosed with myelofibrosis in April 2020, and yeah, it was quite a shock. It was just after the first lockdown, and at the end of the day, it was everything was slow, as everybody knows. So you didn't know anything about the disease. At the end of the day, you were left over to Google, and as Danelle said, it's a death sentence to Google things. And so you started learning and you saw that you quickly realized that there's a lot of lack of information. And I started researching, and it's very rare to find something out of South Africa that is relevant to our country, and quite much information available overseas, America, on Mayo Clinic, that kind of platforms. So yeah, the initiative came to start something in South Africa. It didn't stay South Africa at the end of the day. It became much bigger, also international. And yeah, it's difficult. A lot of people ask you, what is myelofibrosis? And to explain it is not that easy. And they quickly lose interest. So if you're not open-minded, you feel alone. If you don't have a support system, you also feel quite alone in this journey. I'm fortunate enough to have a good support system from home and from work. So that's an advantage for me to be positive, and that gives me the courage, encouragement, and time to see where I can help people and share my journey. Hopefully my journey can motivate someone else to get where they need to be. So yeah, it's not always easy, and to understand how it works, it's even more difficult, especially when you go see your doctor. The terminology they always use, it's not always easy to understand what it is. So then again, it's a journey to research, and I have a strong belief that we learn with our doctors every day. Within my research, I found that there is other people that I'm talking to that is similar to almost the same diagnosis as what I have, but the medical care they take and what I have, it's not the same. They had the same medication and the same procedures as what I had, and it didn't work for them. So it's very scary to think that it's not the same as any other regular cancer, where there's a step plan to get through things. And at the end of the day, it can give you some time to think either way, to the wrong side or right side. And you can quickly get into depression. I went through the different stages. And yeah, so with the support system and family I have, that helped me a lot. And yeah, it's a bit difficult sometimes. So I don't know what's going to happen in the future. I believe there is a better future, and the doctors is working hard. My doctor personally is he's quite active within it, and I appreciate him as well, because he's not afraid to tell you. He has to find out if you have a question. So that's basically the long and the short of my journey with this.
Thank you very much, Corno. You know, we have these webinars on lots of different rare diseases and conditions, but so much of there's so many commonalities. Some of the things that you've said is, you know, there's just no information or contact points, and it can just make such a difference when you do connect. But what both of you have said, Corno and Danelle, is that you find out that you were finally diagnosed, and then you don't know anything about this condition. It's almost like you step over a boundary into this world and this community of rare diseases, and it's not somewhere that you thought you would end up being. And I think that's common to all of us that are a part of this community and have been affected by rare diseases, either directly or with a family member. So thank you for your honesty and just making yourself vulnerable and telling us about how your journey onto where you are now. So thank you. We'll come back with some more questions in the chat for you. If we can move on now to Cole Cameron. And so Cole Cameron is based at the Ngazi Foundation now. He's had an interesting journey. He started working at an NPO in the arts, Artists Against AIDS. So he's coming from an arts background, but he's very associated and keenly associates himself with health and education issues, and dissemination of information is vital when you're a part of any social struggle. He's involved in lobbying and engaging and just, you know, leveraging and ensuring that there's accountability from power structures. And he's had experience, as many of us have had, of cancer in our own families, and it has led him, he's now an advocate of the Ngazi Foundation, which has a mission to establish world-class hematology facilities in Port Elizabeth as a blueprint for Southern Africa and the rest of the developing world. And I'm going to hand over to Cole now, just to tell us a little bit more about his work at Ngazi and its role in as an NPO in Southern Africa. Over to you, Cole.
Thank you, Helen. Ngazi was formed because there just wasn't a dedicated hematology NGO in South Africa, certainly not doing services and facilities. And we grew up in the Eastern Cape out of necessity. We had to lobby, we had to push and initially work with government to try and get a facility going in this province. And through the years, we've been fortunate to be able to help other provinces and educate throughout the country, both patients and professional education. A lot of the problems that we continue to face is hematology is considered quaternary medicine, and the focus is always, even pre-COVID, was on primary medicine, which of course you understand. But that is not always so, because there's a lot of primary overlap. For instance, anemia in Africa, which is a hematological disease. So these are issues that we continue to face. I'll pick up on what Dr. Ashmore said. Access, big issue. I mean, the cost of a bone marrow biopsy, for instance, is more than 10,000 Rand. And not all state centers for hematology can even do a bone marrow biopsy. The better medical aids will pay, but the poorer medical aids won't. So you start with not actually picking up the disease in the first place. And well, treatment, of course, can be pricey as well. Patient support, I think I picked that as well in Dr. Ashmore's presentation. There is very little patient support, again, having said that hematology is quaternary medicine. There's very little support because the diseases are often very rare. ITP and myelofibrosis are rare diseases. So we have to reach across the seas. We have to search Facebook, search websites to try and get information. But we carry on. We try to create structures, and hopefully working in conjunction, standing shoulder to shoulder with other NGOs, particularly rare diseases, we keep going. Helen, is there anything else you'd kind of like me to say? An issue that was brought to me by one of the doctors, I can just at the end say that many of our, excuse my hands, I see my hands are constantly coming up. I speak with my hands, my apologies. Many of our patients our state patients often have to stay overnight in 2 state hospitals just to get to a center where they can be treated. So it's these little things that that are over and above the disease itself that have to be addressed.
Cole, how are you advocating for improving access to treatment specifically in state and in private?
Well, we generally don't deal directly with patients. We do our work by providing facilities, upgrading facilities, and doing professional education, because that's the way we can spot diagnoses in. We use the GPs to help spot the diseases, and that is our work. Our work is primarily education and facilities.
Okay, and I'm just curious, so that's in state and private, because I'm just thinking if somebody is diagnosed in state, and I'm not sure of the numbers that we're talking about here, then what happens? I mean, you say they're going to be referred to tertiary level care, but then what treatment are they going to be offered? I mean, in the rare case that they are diagnosed.
Well, there's a big discrepancy between private and state. For instance, there'll be certain drugs that cannot be given to them in state because there just isn't the budget. There already is a massive, this dual health system we have in this country. It's not a one size fits all. State patients don't get as much as private. Does that answer the question, Helen?
Yeah, thanks, Cole. I think we've got more questions. If we can just ask all the panelists just to switch on their videos so we can just get some discussion, and feel free to ask each other questions here as well, because it's a great opportunity. So I just would like to go back to Danelle and Corno just to find out what is the one thing that has really helped you, and what is the one thing that you have found the hardest? And just, I mean, thinking in terms of if you were to meet somebody now or speak to somebody right now that was newly diagnosed today, what would you say to them? Just in terms of practicalities.
Okay, I'll go first. I think if I met someone today and they've been diagnosed recently, I would say, don't Google it. Don't Google it. Yes. It's not a death sentence. It's just the path is just a little bit more thorny and with rocks than the normal path. You just need to trust in yourself and trust in your support system.
And what's been the hardest for you, Danelle?
I think the hardest for me was not being able to show how I'm feeling. The thing that I really struggle with still today is being able to tell someone how I feel inside, like my body is aching or that type of stuff, because for normal people, that's just whining about silly stuff. But for me, it's excessive. It's like, it feels like somebody has punched me in the gut. It's not just a tummy ache. I think that's the thing I struggle with the most, is people not really understanding what you're going through.
Thanks, Danelle. Corno?
I would say if I have to meet somebody, the most important thing I would say is talk about it. And that's only the way we're going to get out there. Awareness is by talking about it. And I'm not only saying about talking about the disease. Talk about how you feel, how you experience it. Talk about how your family is experiencing it, because yes, you are diagnosed with this heavy weight, but your family actually has the same diagnosis as well, because they are going through the same thing. So it's important for you to talk about it so that your family know your state of mindset, and that will bring comfort to them, because as soon as you stop talking, they stop talking. It's like a touchy-feely subject, and everybody's afraid to talk about it. So I think that is important, because a lot of people are afraid. The scary thing, I talk to some people across the world, not only in South Africa, you get victimized at work. If they know, they're afraid the work will find out about their diagnosis, and they will be victimized because they can't do the work. And you can actually call it a career limiting move, because now how sick are you going to be? How many times are you going to be off at a day? That kind of stuff. So the more people talk about it, I believe the more people will be open for it and understand that, yes, you have bad days and you have your fatigue days, and like Danelle said, your body ache days and everything, but you are still able to do your part. And I personally, I don't like to be placed on a pedestal and said, you're sick, you have to sit down. So that's my hardest part of the whole thing, is to not do what I really want to do when I want to do it. So sometimes I can be very active, and then you have that one day where you can push yourself as hard as you want. You just can't do it. So I think that's the hardest for me, is me being a heavy earth-moving mechanic. I don't believe I will be able to go back full on that ever again. But yes, you try every day and take a step forward every day. You don't have to take steps.
Okay, thanks, Corno. That's very helpful. Dr. Ashmore, a question in the chat about the importance of, how important is it to have a good relationship and level of trust between the healthcare professional and patient? And then my add-on to that would be, I mean, how many relevant specialists do we have like you in the country? And I don't know the numbers. I mean, it's very few, it's very rare diseases that we're talking about, but are there enough? I mean, you mentioned as one of your constraints to services that there's a shortage. So can you tell us a bit more about that, as well as the whole relationship, please?
So in terms of the relationship, it's absolutely the cornerstone. So certainly I think the difficulty in a state sector is that you don't have a choice. You referred to a quaternary center, and that's your doctor. And often it'll be, because they're training institutions, you'll rotate through different doctors, and it's quite difficult to build a relationship. So I think that can be challenging. And I certainly don't profess to be everybody's doctor. There's certain patients that will connect with me and others who do not. And it's just, part of it is a personality thing, and part of it is the approach that I take and all of those things. So I'm not professing to be the right fit for everybody, but I think what's nice about the private sector is that you get to choose. In the state sector, you can't, like I said, and it's such an important thing, because patients will, when I've certainly seen it, when somebody doesn't have trust in their doctor and feels like they may be judged according to what they're going to say, then they often don't give the full information. And also just some of these things are difficult to open up about. So I think it's been illustrated very well by the two patients here, is that some of these things are very personal. So to tell your doctor that you're feeling really depressed and anxious and, all of those things, if you don't connect with your doctor, you won't tell them that. In the same way, if you're really struggling with side effects of treatment, you're just going to tell them, somebody who shouts at you if you miss your pills, you're not going to tell them that you missed your pills and why, and the importance is why. And then, as the doctor, you can potentially address or switch or just discuss it so the person doesn't feel so alone. So I think that relationship is very important. In terms of your follow-up question, how many hematologists are there? Not many. So I think it's around 30 in the country. More than half are in the state sector, in various academic institutions. So there's an institution in Cape Town, There's KZN, and then Johannesburg, between Baragwanath and Charlotte Maxeke. And then in the private sector, there's again these little satellite institutes. It's a small community, so we all know each other, but it is small. So a lot of these conditions are managed actually by a physician who may have a special interest, or they're just doing the best they can in the circumstances where they just don't have access to referral centers.
Thanks. And then I guess this is a question in follow-up to that, because I think it's that this whole advocate, building awareness and understanding and education just to promote that diagnosis with these limited numbers of relevant healthcare professionals. Is there a role here, or are genetic counselors playing a role just to provide that initial counseling, or are they not in the loop, so to speak, in terms of counseling for newly diagnosed patients to understand, the prognosis, the risk of reoccurrence in family members and so on? And is that a role that could be played more in your area of work, Cole, for the education side?
Oh, certainly. As far as I know, and I defer to Dr. Ashmore here, there's very few dedicated, let's say, social workers that know hematology backwards that can actually advise. It's usually, we would sort of use oncology social workers to fill in some of the gaps. But yes, in answer to the question, we most certainly, it would be, we do need people that can deal with the patients and be the interface often between the doctor and themselves in this challenging time.
I'm certainly not aware of anywhere I've worked where there's genetic counseling. I think what often happens in the state sector is there will be a very well-informed and nice nurse who takes on that role. Sometimes the doctors, if they have a special interest, will take on that role, but it's not something that's commonly found at all.
And even then, we have so few hematological nurses in this country, which is another issue. So I'm sure you'll agree, Dr. Ashmore, that this is another ongoing issue that we have.
Huge. And I mean, certainly, whether it's in the state or the private sector, it's a sort of a labor of love. And a lot of times nurses that one spends time training and they're fantastic and they love what they do, but they're not remunerated to that level. And they go elsewhere because they have a family to support.
And this happens also, there used to be a network of genetic nurses across the country who were then reabsorbed into primary healthcare. And also trained and so on, but are reabsorbed into other areas and we lose them. And it's interesting, in Eastern Cape, there are no genetic counsellors. There are only genetic counsellors in South Africa, in Gauteng, and currently it's Gauteng and Western Cape. There are none in any other provinces, although obviously I think that the one thing that COVID has done is, promoted telemedicine and the ability of virtual consultations. While not ideal, they are providing an option. But I think Cole's hit the nail on the head, and the whole role of the nurse is vital because they're often the connection point in the community as well.
And also in the languages, like for instance, here we use a social worker that we pay for in our unit, that can at least bridge the gap, just the language gap, never mind the understanding of the cancer journey or the blood disease journey.
And Corno has just commented that medication is also a big problem because people can't afford to have a comfortable life. And is that regarding to how does it work, for example, in the private sector, since that's the only sector where care is essentially provided in the terms of these personalized therapies? And it's ironic, is it not, that I mean, you ended your presentation, Dr. Ashmore, saying, you know, the future looks bright, but the future looks bright for those that can access the care of the treatments.
100%. And obviously that's the world over. I mean, it's the same in America as it is in, you know, in Europe. You have to be on specific, you know, yes lists before you can have access in a sort of a wider version. In the private sector, it would be very unusual not to have access to everything I've described, providing you have a doctor who will fight for you. So, for example, recently, a patient was referred who'd seen a whole bunch of people, and she qualified for Jakavi. She had another preceding condition, ended up with myelofibrosis as a complication, and everyone had just taken the no as the answer. Took a couple of months, but you know, you sort of push and say, actually, this is a PMB condition. She has tried everything else. This is what the law says. If you'd like to contradict the law, go for it. And then there are kind of organizations that cover co-payments. So, you know, you can usually push to get the thing authorized, but then co-payments become ludicrous, so that it's you essentially saying no, but just not in those words. So there are a lot of organizations now that will cover the co-payments for medications like Jakavi, for example.
What kinds of organizations are those? International NPOs or
local?
Local.
Some of it is actually drug company funded, and some of it is NGO. And essentially it's a way of covering those shortfalls. And most of them will cover up to 25%.
Oh, wow, oh, that's helpful. Do you foresee it changing? I mean, I know the NHI, the National Health Insurance Initiative, is probably, well, most likely going to be further delayed in its implementation with the emergency COVID response that's had to be mounted. How do you see, with these specific conditions, treatment potentially changing in the future? I mean, accessibility to diagnosis and treatment.
Look, it's a concern, because I think something that, I mean, I've certainly written formal concerns about NHI to Parliament. Obviously, I have no idea if they actually read them or not. But as I figured it was best to put my name down on paper, and why. But I think from my concern is dropping quality in one area rather than raising it in another. And I think that's the major concern. I'd much rather see a system that raises up the quality in the state sector, rather than everyone being kind of subject to poorer quality. So I think even if it's in a, you know, the same that in first world countries, not everybody has access to everything. But I just think there are different ways to elevate rather than bring down.
No, so true, it really is. And maybe one day we'll have enough resources so everybody's treatment can improve.
100%.
So I see we're running out of time now, but if I may, I'd like to just go around each of the panelists, and if you'd just like to sum up just what you feel is the most important from your perspective with regards to these conditions. And if we can start with Danelle, please.
I think the most important thing to remember when dealing with ITP is that, like there has been said, not every treatment is going to work for everyone. When I was in state care, I was on prednisone for 5 years and my platelets never went up past 20K. And when I moved to the private sector and had a medical aid and they placed me on azathioprine, my platelets went up to 85, which had never happened before. So I think the important thing is to find someone you're comfortable with as a doctor and who, like there has been said, that was willing to go the extra mile for you and where you can be open to, because at the end of the day, it's important to them, for yourself, that they have to know what's going on in your life. So I think the important thing is, don't be afraid to ask questions, because I only found out that ITP is a cancer when I moved to the private sector. Before that, they never said anything about that. They just said, you have ITP. That's it. So I think it's important to get yourself a support system, talk to somebody you trust, and get a doctor you trust as well, because that's the most important thing.
Thanks, Danelle. Some very good points there. And Corno, would you like to add your final thoughts?
Well, I would like to repeat that don't give up and ask questions, and like Dr. Ashmore and Danelle said, find the doctor that you are comfortable with and ask questions. So it's important to challenge the doctors, not to be arrogant, but to challenge them. And maybe you have a valid question that's valid to raise elsewhere. They don't know how you feel, and as we all know, not everybody has the same symptoms on the same time of the same medication. So it is important to share with your doctor how you feel, and then on a family point of view, talk to your family, involve them, so that they also know where you're at that moment.
So true, Corno. I mean, we've got to keep the communication lines open. But I think COVID's put us under even more pressure in those situations, but so true. Cole, can I ask you to wrap up your thoughts, please?
Yes, I think it's important to be a clear and persistent voice continuously, because we are a small community and we're often sidelined by bigger issues, COVID notwithstanding, and we were before. Keep on being a very clear voice, because yes, there may not be as many sufferers, but if you're one of them, you need a voice.
Absolutely. Yeah, so true. So true, Cole. And thanks, Cole. And Dr. Ashmore, would you like to give us your final thoughts, please?
Look, I mean, I think it's been summed up very well by the others. The only thing I would add is, I think my role is very clear as a doctor, and that's to listen. It's not actually, I mean, today, obviously, I've been doing a hell of a lot of talking, but my role with a patient is to listen. And I think as doctors, we can do an awful lot more of that.
So true. Yeah, so thank you so much, all of you. So we've got to ask questions. We've got to have that support system. We've got to keep talking, developing that, trusted relationship with a doctor that you're comfortable with to oversee your care. Don't give up. Be that clear and persistent voice as a community. And for those healthcare professionals out there, listen to your patients and listen more. So thank you so much. I think it's been a real eye-opener tonight, and this is going to go out there and be online for others to listen at a later date. And yeah, so I think this is a further step that we have towards building awareness here and just being that clear and persistent voice that we need to be. So thank you everybody for your time. And if there's any more questions that come through, we will forward them to you, to who we think could potentially answer them. But thank you for your time. Thank you again to Novartis for funding this and making it possible. And here we go. It's another building block in that, that approach to leveraging for improved services in South Africa. So thank you so much, and stay safe, everybody.